Hello and welcome back to our new controversies in rectal cancer. This collection of video content will allow us to explore some of those difficult decisions that our multidisciplinary team members sometimes have to make for these patients. You'll be able to watch renowned clinicians in the field give expert lectures on controversial topics. See our expert MDT panel discuss complex cases and enjoy some critical analysis and commentary. Each episode will have a theme that runs through the broadcast. And in this episode, we'll be thinking about strategies for organ preservation, where the morbidity and mortality of radical surgery can sometimes be avoided. First up is Fraser Smith from the Clatterbridge Cancer Centre in Liverpool to talk to us about this in more detail. I hope you enjoy watching.
Hello, my name is Fraser Smith. I'm a consultant surgeon working in Liverpool. I'd like to thank Greg Wynn and the ICENI group for inviting me to give this talk. So it's a real honour. I've been asked to talk about who is suitable for organ preservation in rectal cancer and how should this be achieved in current evidence. I've also been asked to talk about what will related clinical management look like in 10 years' time. So my remit is who is suitable for organ preservation, but I'd like to discuss first what actually is organ preservation. Then I'd like to discuss the different areas that there are for organ preservation. One is in the context of locally advanced rectal cancers, and then you've got people that have a complete clinical response, the so-called watch and wait management. Then you've got the concept of giving neoadjuvant therapy and performing a local excision rather than radical surgery. The other context for organ preservation is for early rectal cancer, and here you can either locally excise the tumour on its own or give chemotherapy or radiotherapy in conjunction. I'd then like to talk about the current evidence for each subtype, and importantly, I'd like to discuss the concept of is organ preservation synonymous with sphincter preservation for patients. I'd like to talk about who's suitable, some of the legal and moral responsibilities of this line of work, and an overview of the future directions and vision of rectal cancer care in 10 years' time. So up until now, the cornerstone of rectal cancer management has been total mesorectal excision. This has been shown through multiple research projects to provide optimal local control for rectal cancer. And within this, the main tenet is to remove rectal cancer with the mesorectum along clearly defined anatomical planes. In the 1990s, however, evidence showed that giving radiotherapy and chemoradiation in a neoadjuvant or pre-surgical setting had beneficial effects for patients. A side effect of it was, though, that in a certain number of cases, it had caused a tumour to completely disappear or to be downstaged to a very early stage that may be compatible with less radical treatment. And this then brought around general thinking amongst surgical groups that actually radical surgery in this group of patients with an excellent response to chemoradiation may be over-treatment for this subset of patients. And when you think about it, radical surgery is a very big deal. Patients have to come into a hospital, have a prolonged operation. Most people having rectal cancer surgery will have a stoma bag, either temporary or permanent. For people with abdominal perineal excisions, wound infections and wound healing problems are a major component. And then there's the less talked about but very important for people's survivorship, problems with pelvic organ dysfunction, impotence, sexual dysfunction, bladder dysfunction. And when you consider that looking at the pathology reports of these people, that 10 to 30% of people do not have a single cancer cell in the resected specimen, and many more are downstage to very early stage, you can see then that this is a very significant problem. So looking at organ preservation, the concept of organ preservation has been around for some time, and actually when you look at it, there's been techniques to remove objects from the rectum and perineum for hundreds if not thousands of years. This slide, for example, shows a photograph of transanal extraction implements found in Pompeii, and I took this when I was on holiday recently in Kos in Greece. More recently, in the 80s and 90s, the concept of a laparoendoscopic hybrid, or TEMS, first proposed by Gerhard Buess, came into existence, whereby transanal excision could be done in a very precise manner. Then, in the early 2000s, this whole surgical community was turned upon its head by Angelita Habergama, a now very famous Brazilian surgeon, who posed the question, well, why operate at all in rectal cancer if we suspect that there's no cancer left? So now rectal cancer management has become extremely complex, but you've got two main treatment strategies. One is total mesorectal excision. This is the gold standard, and here you can aim for sphincter preservation. And then you've got local excision and watch and wait strategies aimed to avoid overtreatment, aimed to provide equivalent oncological outcomes with less morbidity, aiming for organ preservation. So I'd like to now talk about the current evidence for organ preserving techniques. Firstly, I'm going to talk about in the scenario of locally advanced rectal cancer. Here, essentially patients are getting something for nothing because they're receiving neoadjuvant chemoradiation anyway as a part of their treatment. The possibility of organ preservation is opportunistic. They're getting something for nothing in so much as you can discuss it with patients, and if they're interested in the concept and if they seem to have had a good response, you can offer them organ preservation, and they're not being given chemotherapy or radiotherapy, if you like, unnecessarily. The first non-operative strategy I'd like to talk about in this regard is watch and wait therapy. Again, first proposed by Angelita Habergama from Sao Paulo in Brazil. And this slide shows the now seminal findings whereby patients that did not undergo surgery, that had a supposed complete clinical response where there was no tumour to see or feel after chemoradiotherapy, actually had slightly better outcomes than people that underwent radical surgery and were found to have no residual disease. Now, at the time when this study came out, these results were extremely controversial. I would go so far as to say no one believed her. But having an interest in rectal cancer already, I saw that there was potentially, this was a revolutionary treatment. And I actually went to Brazil myself in 2009. I met Professor Habergama, met the patients, met her famous sidekick, Rodrigo Perez, saw that they were meticulous at taking information from patients, collecting tumour specimens from people, conducting scientific research on it. And I was able to see firsthand that this actually was a very real technique. However, other centres tried this technique and found that their early results were not reproducible, and the question was why. Basically, no one had actually defined what a complete response was, and it was only in 2010 when Professor Angelita and other co-authors, including Greg Wynn of the ICENI Centre, published this now seminal paper defining what exactly a complete response was. That was nothing to see or feel, specifically whitening of the mucosa, telangiectasia, and you can clearly see in this photograph what a complete response is. However, the main concern with watch and wait is that in the absence of a surgical resection, even if it appears to have a complete response, there's going to be subclinical residual cancer cells remaining in the mesorectum and the rectal tissues that are going to remanifest later as an inoperable local recurrence or spread through the body and compromise survival. And there's a very strong feeling amongst the surgical community that this treatment should not be offered to patients on safety grounds until it's substantiated by level 1 data, specifically a randomised controlled trial. Within this context, myself and a number of other co-authors from the UK published this paper in the British Medical Journal last year. This was in the uncertainties section and essentially was a systematic review of all the published evidence on watch and wait so far. Now, this is a busy slide, but importantly it shows that already there's been 2 study-level meta-analyses, 1 individual participant-level meta-analysis, 1 match-controlled study, 1 registry-based pooled analysis, and 1 meta-analysis and salvage surgery outcomes. So there's a good amount of data there. Specifically, we went through this data looking at local regrowth rates, surgical salvage rates, disease-free survival, and overall survival. And what we found was that the local regrowth rates are approximately 15 to 33%, and they're most common in the first 2 years. Of these people that undergo local regrowth, the majority can be surgically salvaged. The main single centre series ranged from somewhere between 83 to 95% successful salvage. There is an international watch and wait database that reported slightly lower numbers at 69%, but the authors of this paper felt that that number represented underreporting. Importantly and crucially, disease-free and overall survival within these patients that developed a regrowth and then were salvaged were actually similar to patients undergoing an index surgical resection. Now, there are limitations with the current data, and we went through these in some detail in our study. In the absence of a randomised controlled trial, it raises a concern of treatment selection bias. This is partly, but not totally, accounted for using methodologies such as propensity score matching, which some of these trials have done. There could be between-study heterogeneity for key predictors of outcomes, such as age, performance status, and cancer stage. The definition of locally advanced rectal cancer is not internationally standardised, resulting in variations in patient selection for watch and wait and outcomes. There's going to be variations in centre-level expertise, treatment and follow-up protocols. And finally, patient choice can influence outcomes, and it's difficult to take this into account in analyses. So what about people who still refuse to entertain the idea until a published randomised controlled trial comes out? Well, we searched clinicaltrials.gov to identify ongoing trials and found 16 registered proposals to the search watch and wait in rectal cancer. Only one protocol out of these was designed to evaluate the equivalence in oncological outcomes, namely 3-year disease-free survival, between patients with locally advanced rectal cancer treated with chemoradiation and a complete response randomised to either watch and wait and surgery. This study is based in Sao Paulo, Brazil. Interestingly, not Professor Angelita's unit, but another unit. So this will be the first randomised trial. It's meant to be reported in 2019, so in theory it should come out soon. And it will certainly be very important data. However, with a target of only 150 patients, to us it seemed underpowered. And in the UK, at least, its inclusion criteria would include a lot of tumours that were at a far earlier stage that would be considered for long-course chemoradiation. Now, I've heard it through the grapevine, and I can't substantiate it, that the study's not recruiting well, potentially because people with a complete response can go down the road to Professor Angelita's unit and be treated with watch and wait. But interestingly, of the other 15 trials looking at watch and wait, they were all part of trial protocols that included organ preservation as part of the outcome. Specifically, these were if tumours had a poor response to chemoradiation, they would receive radical surgery. If they had a good or near complete response, they would receive a local excision. And if they appeared to have a complete response, they would undergo watch and wait. So for those people waiting for the randomised controlled trial, this trial is unlikely to materialise anytime soon. There's many confounding factors in such a trial. It's our proposal that good quality registry data, an experienced team, a robust surveillance programme and good quality consent are going to be key for this whole issue. And even if there was a trial, like the people in Sao Paulo, they're going to vote with their feet. Who would want to enter a trial if they had a suspected complete response and might be able to avoid surgery? Now, interestingly, just last week, I got the new NICE guidance draft for consultation into my inbox. And there is some mention of watch and wait in this, which is the first time that the NICE guidelines specifically deal with this in the setting of locally advanced rectal cancer. Interestingly, they do state that people who wish to defer surgery, importantly following a complete radiological and clinical response, should be informed that there's no prognostic factors to guide selection for this to help them avoid regret over their future treatment choices. The committee recommended that it should only be offered in the context of a clinical trial or national registry, of which there are 2 in existence, one in the UK and one internationally. And very interestingly, the committee at the moment feel that they chose not to make a recommendation for a trial because they felt this question would be better answered by a good database such as the ones that are in existence. There are other issues, though, with watch and wait for a complete clinical response. And these are that while the majority of people feel a complete response is as described in the Haber-Gamma paper, interestingly, the Haber-Gamma paper in 2010 described what an incomplete response was, and that's any sort of ulceration, irregularity, a stenosis, or basically any sort of residual abnormality. And in 2010, when I was still in surgical training, I worked in Dublin, and the professor of pathology there had taken, I don't think he actually realised why at the time he was taking them, but he'd taken photographs of ex vivo surgical resection specimens showing luminal views of rectal cancer after chemoradiation. So we had the idea of very simply comparing what the mucosal aspect looked like in patients that had and had not had a complete pathological response to chemoradiation. We looked at over 200 rectal cancers and basically asked the simple question, is a complete clinical response present when patients have a complete pathological response? And interestingly, we found that it wasn't. In fact, in this study, we found that only 39% of patients with a complete pathological response had a complete clinical response. So while that data was interesting, it needed to be validated in another centre. And then in 2012-13, when I was doing a fellowship in America, essentially we repeated this study, and again, in a different cohort of patients, over 200 patients, in a different country, different continent, we found that 74% of patients with a complete pathological response did not have a complete clinical response. Again, most of them had ulcers. And you can see here very clearly these incomplete clinical responses in patients with a complete pathological response. So just to make things more complicated, for the majority of people that have a complete pathological response actually don't have a complete clinical response by the Haber-Gamma criteria. There often will be something to see endoscopically. And here you can see in this slide very compellingly that the top row are people with a complete pathological response with big ulcers, and the bottom row are people with T3N1 disease with arguably slightly smaller ulcers. So, can we manage incomplete responses by watch and wait too? Well, this is an example of a very obvious tumour that has not responded to chemoradiation, and I think common sense says that you wouldn't consider managing this by watch and wait. But what about these smaller ones, as we showed before? They look like they've had a good response, but then pathologically it says something very different. Interestingly though, people around the world interested in watch and wait are now managing incomplete responses by watch and wait. For example, this important study published in the Lancet Oncology in 2015, only 10% of patients in that study, of patients managed by watch and wait, had what would be classically defined as a complete response. The Dutch group, for example, again includes small flat ulcers with smooth edges without signs of residual polypoid tissue as complete responders. The problem with this, though, is it makes a very objective endpoint subjective and therefore open to error. So one other method of managing patients with organ preservation after chemoradiation is local excision. The first person to do the first person to publish in local excision after chemoradiation was Gerard Marks, who's a fantastic individual who hails from Philadelphia. And he, in 1990, published this study in 14 patients, 12 of which were too unfit for radical surgery, and 2 were to confirm an apparent complete clinical response. This was a time when the concept of watch and wait was only just becoming accepted. And what they looked at was at 21%, 2 years follow-up, people had a local recurrence, which was probably pretty good for this group. The question is, though, does the residual mucosal abnormality actually represent intramural disease? Perhaps what you see is just the tip of the iceberg, like the slide I showed a few previously. We've looked into this in some detail, and what's interesting is that the way tumours respond to chemoradiation is not quite what you think. You suspect it just shrinks down, but actually the majority of tumour, when it responds to chemoradiation, fragments in amongst fibrotic cells. This then gave us the idea that perhaps you could get tumour cells under normal appearing mucosa beside these residual mucosal abnormalities. One of the studies I did when I was in Cleveland Clinic looked at this phenomenon in resected rectal cancers, and we found that actually this phenomenon was present in 71% of patients. The maximum distance of this scatter was 9 millimeters, and what we found is as the YPT stage increased, the distance of tumour scatter increased. And you can see here in this slide that there's a focus of tumour underneath the residual abnormality. This study, again from an American group, is even more compelling. Using a slightly different sampling technique, this group found that for a bigger cancer that had shrunk, residual tumour cells were found scattered under normal mucosa up to 3 centimetres distant to where the abnormality was. So when you're considering doing a local excision, especially in big cancers that have shrunk, this might mean, or we proposed that this might mean, that in fact you could excise something with clear margins, but you may be excising through scatter, leaving tissue behind. Now, this problem is completely obviated in a total mesorectal excision because everything goes. However, in local excision, you're trying to get the same oncological result with taking a little wedge of tissue out, and you can see how you might leave residual tumour behind. So we looked at this in a big study published in 2017 in Diseases of Colon and Rectum, and what we looked at was how local excision was being performed and how that might affect things in relation to tumour scatter. So this is a busy slide, but what it shows you is that the data so far includes approximately 300 to 400 patients with T3 tumours. Again, looking at UK data, is T3 actually locally advanced? Should it receive chemoradiation? In UK NICE guidelines, probably a lot of these wouldn't, but it's still interesting data. We looked at the size of tumours included at baseline, and what we found was that only 5 studies limited it to small tumours less than 3 or 2 centimetres. The reason this is important is if you're doing a local excision in something that's 3 centimetres, you can theoretically excise that whole area even after chemoradiation, so you're aiming to get all the tumour out. If you've got a big tumour that shrinks down to a small residual abnormality, just because you excise the abnormality, coming back to this previous study, you can see here that you could leave scatter behind, so it could be a big problem. The other thing that's important, certainly in TME and pathological correlation, is the margins. And we looked at what margins were used in all the studies of local excision. Interestingly, a large number of studies didn't state what margins they used. And of the ones that did, the resection margins were only between 0.5 and 1 centimetre for the majority. And importantly, they were based on the residual mucosal abnormality, not the original tumour. The other thing we looked at was the depth of excision. And what you can see is the majority of studies have done a so-called full thickness excision down to the level of the mesorectal fat, and only 4 studies excised the whole residual mucosal abnormality down to the mesorectal fascia. And interestingly, Emanuele Zocchi, who is an Italian surgeon with by far the biggest published series in this area, routinely excises down to the mesorectalic fascia, essentially doing a transanal sort of total mesorectal excision. And his results, certainly in the literature, are extremely good. And 4 studies gave no details. And this is an example of Emanuele Zocchi's, he calls it an inverse pyramid resection. And you can see here the red arrow pointing to a full thickness excision, but Professor Zocchi takes all the mesorectum down to the fascia. The other aspect we looked at is the location of tumours. And interestingly, the majority of studies looking at local excision after chemoradiation looked at tumours less than 6 centimetres from the anal verge. Now, why is this important? Well, if you consider a higher tumour, you're going to have a bigger buffer in mesorectum, meaning that if there are adverse features or you need to do a follow-on surgery, you should be able to still have reasonable planes to do a radical operation with a radical sphincter saving operation. If, however, you've got a low tumour and you do a local excision, you're going to be disrupting the planes for radical surgery, especially if you're going to consider sphincter saving surgery. And you can see here these images by Eric Rillier of the tissue planes for low colon anastomosis. The other thing is, if you then follow on after local excision, you have much worse outcomes. And this, again, this is actually a table from Eric Rillier's paper in the GRECR2. And you can see here that for people that had a local excision followed by completion surgery, there was a far higher stoma rate, 25%, compared to people that underwent total mesorectal excision alone. And across the board, really, the outcomes were worse in this study. So what about people that have a local excision and have adverse pathology? What happens to them? Well, we looked at that in our study. What is the strategy to convert to radical surgery? 15 studies described a strategy to convert to radical surgery. However, the criteria to do this varied immensely amongst all the studies, and there was a huge variability and very little consistency. Then the other interesting point is salvage surgery always necessary? In Eric Rillier's study, he showed that of the patients with T2 pathology that had radical surgery, only 8% of them had a nodal disease, and postulates that not all patients need completion surgery, and really being more selective is going to be the key to making this technique work. So the other interesting phenomenon is, do patients actually want salvage after local excision? Of these studies, 11 reported details of patients who were offered salvage, and the majority described some patients refusing it. For example, the largest example of this was Christoph Buiko's study, where 69% of patients actually refused surgical salvage where adverse features were found in their locally excised specimen. So coming back on our initial hypothesis with this study was to look at the impact of margin status and local recurrence. We postulated that the majority of local recurrences would be in R0 resections because you're leaving residual scatter behind. We found, looking at the literature, that this was in fact true, that the majority of these recurrences was where they were R0. So this substantiates potentially our theory. One of the authors in this study was Bill Heald, who really felt very strongly that we included the caveats of local excision after chemoradiation, and there really can be quite considerable morbidity after this. For example, one study by Rectal et al., they had to discontinue their study after 7 of the 14 patients' wounds broke down with serious consequences. Additional consequences include severe pain, abscesses, fistulas, the possible need for defunctioning, and compromising the planes and outcomes after total mesorectal excision. In addition, when you get a local recurrence in a wound breakdown cavity, it's an extremely difficult thing to manage. Salvage surgery is difficult and associated with the high R1 resection and additional local recurrence. So to summarise the assessment of local excision techniques, there's almost complete lack of standardisation in the techniques described. The results are difficult to interpret because it's a very heterogeneous patient cohort. Many studies don't mention lateral excision margins. Many studies include large locally advanced tumours at baseline. There's many post-operative complications and morbidities. There's no standardisation in criteria for follow-on TME. Most series report patients refusing salvage surgery, and most local recurrences occur in patients with so-called negative margins. So despite all of this, what's interesting and I guess worrying in equal measure is that local excision now features very strongly in the trials looking at this endpoint of organ preservation. In particular, it's used in the context of near complete responses. As I think I said in an earlier slide, the general format of these studies, of which there are several, is that if a patient has a poor response, they get radical surgery. If they have a good or near complete response, they have a local excision. And if they have a complete response, they have watch and wait. So I guess the proof will be in the pudding, but it's something I think certainly we need to consider, especially in light of the fact that stage 1 to 3 tumours, of which a lot of these studies are looking at, could have curative surgery with no radiation. So the last thing in locally advanced tumours that I feel compelled to talk about, number one, because it's an interesting technique, but number two, because the world's centre of excellence for this is in Liverpool, where I come from. And this is Professor Mint, who is the leading expert in contact papillon therapy. He's treated over 1,000 patients with this technique. And basically, it's potentially a very exciting new method for rectal cancer. How it works is basically radiation is delivered straight down a kind of modified proctoscope directly onto the tumour. It's a low energy type of radiation, and it's confined to the aperture of the treatment cone, meaning that uninvolved tissues in the near vicinity don't get any radiation dose at all, or certainly nothing meaningful. At a depth of 2 centimetres, the dose is typically fallen completely away, which means that you can give massive extra doses of extra radiation onto tumours, up to 30 grays per session. Now, the reason this is important is when you look at how rectal cancer cells die, it's directly proportional to the amount of radiotherapy they get. However, there's only so much external beam radiation you can give before there's massive toxicity, and contact therapy provides a way to get around this. It's good for patients because it's ambulatory, the treatment time is a minute or so, and it can be given as a day case. And this is an example from Professor Mint of a tumour that's had a near complete response after chemoradiation and gets a series of contact therapy. And you can see over time, with each dose, it just melts away, leaving a complete response. So we studied this technique. He's got a lot of data, and we've been going through it, trying to publish from that. This particular study we looked at, published in the Red Journal, looked at how to use contact therapy to further treat these so-called near complete responses or residual mucosal abnormalities after chemoradiation. We started off with a bigger patient group, but it was quite heterogeneous, and so it got whittled down just to 83 patients that had a residual mucosal abnormality treated. These included persistent abnormal findings, suspicious of residual cancer, either endoscopically or in rectal exam, that were 3 centimetres or less. Generally speaking, these were patients who were not suitable for surgery who had refused surgery. Now, this is a busy slide, but what I want to show you is that after treated with contact therapy, 63% of these patients then ended up with a complete response, of which 86.7% had a sustained response. And of the patients that developed local regrowth and were suitable for salvage, they all underwent salvage. So I think that this is a very interesting technique, and potentially it's the beginnings of the future, and there's now a lot of interest in this technique internationally, and there's going to be a lot more data, I believe, coming out in it soon. So just to summarise this particular aspect of organ preservation, specifically after neoadjuvant chemoradiation, complete response does occur, but seems to complete clinical response does occur, but seems to capture only the minority of patients with a true complete pathological response. The trouble with this concept of a good response or a near complete response is that it incorporates a spectrum from no residual disease to very significant residual disease. Current data shows that watch and wait is relatively safe, but much of this data is based on a complete clinical response and not these shallow ulcers and incomplete responses. But certainly incomplete responses can, in some cases, be followed and ultimately either not change or develop into complete responses over time. Local excision is an option, but it can still be a very morbid procedure. It disrupts the tissue planes for salvage and can disrupt the tissue planes for surveillance, and the criteria to offer salvage are not clear as well. Contact therapy can be used to treat small residual abnormalities after chemoradiation and may be an exciting and emerging option, but needs further investigation. So on to the second part of the talk, organ preservation for early rectal cancer. This is important because tumours are being identified at far earlier stages. You've got the bowel cancer screening programme, you've got all the public health awareness campaigns, and the traditional thinking in early rectal cancer was that really only T1/SM1 cancers with no adverse features could be treated by watch and wait and no follow-on surgery. And once you have additional risk factors such as deeper submucosal invasion, poor differentiation, lymphovascular invasion, etc., it started increasing the odds of having residual disease and started making the recommendation of completion radical surgery more recommended as the safest approach. However, what this has resulted in is a lot of people with very early stage disease having radical surgery and having a permanent stoma. In this publication, nearly 30% of people ended up with a permanent stoma for very early stage disease. So looking at the NICE criteria in the UK, NICE define early rectal cancer slightly differently. Specifically, they define it as T1, T2, N0. And the recommendations from them, I think, are quite forward-thinking. Basically, what they say is you should discuss it in a multidisciplinary team, discuss all the uncertainties around treatment of stage 1 disease, and then take it back to patients and discuss it with them and their family members and decide what's best for the patient. Now again, in my inbox last week came the most recent consultation document about from NICE for the new colorectal guidelines, and interestingly they've done quite in-depth comparisons between all the different techniques for stage 1 disease, specifically comparing total mesorectal excision to transanal excision, endoscopic resection versus transanal excision, transanal excision with radiochemotherapy versus transanal excision alone, contact therapy versus transanal excision. So they've really gone to town in it. And they've looked at the outcome parameters of overall survival, local recurrence, quality of life, and disease-free survival. And it's really interesting what they find, because in the majority of these, they find no difference in the outcomes for any of these parameters, albeit some of them have pretty sketchy level evidence. And for contact therapy, there's actually no evidence either for or against it. But compared to the original surgical thinking, it really shows that there is uncertainty as to what's the best approach in this technique. The ACP-GBI guidelines for malignant polyps are also interesting, because even when the risk of residual disease is assessed as being high, recommending follow-on surgery, the majority of patients in this study, 82%, went on to have radical surgery and did not have any residual cancer left. But still, as a general rule, most low-risk patients with high-risk polyps are usually offered surgery as the safest option. Now we've got the SPEC for the ACP-GBI group going around with roadshows, reinvesting this area and showing us excellent discussions about the uncertainties in this area. This, I think, is a particularly good paper looking at a meta-analysis of oncological outcomes after treating local excision of T1 or T2 rectal cancers with adjuvant chemoradiotherapy. This is by a Dutch group, and Chris Cunningham from Oxford was also on this study. And what this compared was organ preservation after local excision of these early cancers, giving them adjuvant chemoradiation versus completion TME. And what it showed was that the local regrowth rates was slightly higher for adjuvant chemoradiation than TME, 14% compared to 7%. But then it makes the point, well, maybe people would be willing to accept that risk if it meant they didn't have to go on and have a major operation or permanent stoma. We've looked at this exact phenomenon using contact therapy with myself and Professor Minton, our co-authors in Liverpool. And what we found was that we looked at patients that had undergone local excision and were referred to our Centre for Contact Therapy, and they were also given chemoradiotherapy in their local hospital in most cases. We looked at 180 patients in this study. The majority of them, 72%, were T1, 26% were T2, and 2% were T3. Importantly, and I think a fantastic role of contact therapy, 60 patients had R1 resections, meaning that you can give a huge dose of radiotherapy onto this potential residual disease area. All patients received contact therapy. In addition, 110 received chemoradiotherapy and 60 received radiotherapy alone. And after a median follow-up of 36 months, 94% of patients in this group remained free of local recurrence. 11 patients developed a local recurrence, of which 5 underwent salvage surgery. 8 patients developed distant disease, of whom 5 underwent metastasis surgery. And at the last included follow-up, 96% of patients were free of all disease and 94% were stoma-free. So from this, we concluded that contact therapy can be offered in addition to external beam chemoradiotherapy instead of radical surgery as a follow-on treatment after local excision of rectal cancer. The added value of contact therapy, although very compelling in these results, will need to be formally assessed in a clinical trial and in further studies. But certainly, as I said before, if R1 disease, I think it's a fantastic addition. So lastly, I'd like to talk about who is suitable for organ preservation, and I've been a bit naughty because I've added in my own little title is who is suitable to offer organ preservation, because I think this is really important. Obviously, there's some patients who, you know, it's very obvious that they're not going to do well with radical surgery. This first patient is 100 years old, holding his telegram from the Queen. He's a patient of Professor Mintz that was treated successfully with contact therapy. The middle patient is a patient of mine who we've treated again just with contact therapy, but he had T1 or T2 clinically staged rectal cancer right in the dentate line, and he's had previous radiotherapy for prostate cancer. And he again would be a very challenging radical operation, and he seems at the moment, he's over 2 years out, to have had a complete response. And lastly, you can see this lady with severe rheumatoid arthritis. She would never manage a stoma. And so these are patients who, you know, you can intuitively say are candidates for organ preservation. What about other patients? Stomophobic patients, homosexual patients, people with religious belief, young people that just don't want a stoma with body image issues. You know, these are very reasonable people to offer organ preservation. The other thing in my clinic, a lot of people, when you mention a stoma, they say, oh, this is awful, you know, and I say, well, what do you know about stomas? They say, well, my great Auntie Nellie had a stoma and it was awful, it was a glass bottle. And when you look at stoma technology, it really was pretty awful. However, now stoma technology has come on a lot, and interestingly, when you look at the quality of life data, this is a recent paper from Søren Lørberg's group, you can see that actually patients that have an end colostomy rather than the low anterior resection actually had better global health status, particularly less problems with diarrhea and constipation compared with low anterior resection patients. And we live in different times. The stigma of having a stoma is much less than it used to be. People are empowered. The hashtag #MeToo generation. There's sexy lingerie for stomas. There's, you know, support groups. There's Instagram groups. And so basically what you might perceive as being a big problem for a patient might actually empower them. What I'd like to talk about now is the surgeon factors as well. people come to your clinic and they say, what do you think is best, doctor? And you can get surgeons to say, oh, you just need a good operation. It's the safest thing to do. There's also, I think, a lot of pressure on MDTs. If you're in a group think of people that believe that radical surgery is the best treatment, trying to propose organ preservation can be quite difficult and can not be really accepted in these kind of groups. I know that certainly when I've given talks around the country, people have said, oh, could you come to our MDT? You know, people don't really think organ preservation is a good thing. Interestingly, this slide was shown a couple of years ago in Colchester, and it did make me laugh because it is quite funny. But someone said they do believe in organ preservation in its truest sense. The organ should be preserved in a jar outside the body. But, you know, this again was an example from a closed scientific session in Brazil where we're talking about organ preservation and what to do next. And a very senior professor of surgery turned around to me and said, well, my institution, the decision would be simple. The tumour would be in a bucket weeks ago, meaning that everyone should get radical surgery. So how can this potentially, great surgically, oncologically equivalent technique that's good for patients ever get off the ground when there's so much widespread resistance and disbelief around it amongst the surgeons? And I propose our surgeons may be part of the problem. Interestingly, we looked at the referral pattern for people coming to Clatterbridge who wanted watch and wait, and 70% of these patients were suitable for radical surgery. They just didn't want a stoma. And what I know for a fact, because I've operated on at least one of them, is that some of these patients actually never needed an APR in the first place. They could have had a low anterior resection. But not all surgeons can do these. Not everyone can do a colon anastomosis. Would they refer to someone that could? I'm not sure that everyone would. And the worst thing is when you hear people saying, oh, they said they tried to do an APR, a low anterior resection, but they might have to convert to an APR in the operation. I just don't really see how that's reasonable. I think that these people, you either get one or the other and it should be decided before the operation. The other interesting thing is I've seen a few people now being referred by oncologists. Their surgeons say that they need to have a permanent colostomy. But then the patients will say to the oncologist that they don't want radical surgery, and then the oncologist will then refer patients to, for example, Professor Mint, and then they'll go down the organ preserving route. So it's interesting because traditionally rectal cancer has been a surgical disease, but actually potentially it's become an oncological disease. So I find this a very interesting phenomenon. So potentially when the old granny comes to the surgeon and says, what do you think's best, doctor? You need to the doctor should say, well, let's discuss the options and what aspects are important to you and your family and make a best fit for that patient. I mean, for goodness sake, when you get broadband, you can go on to comparethemarket.com and get told all the advantages and disadvantages of each service provider. I don't see why it should be any different for treatment for rectal cancer. And then, of course, people are coming to your clinic with a huge amount of knowledge, and if they don't have it, their family members do. So as surgeons, we need to know all the information about rectal cancer and the alternatives for patients so we can adequately consent them. And this is not just a pipe dream, this is a law. And in the UK, we've written about this in the BMJ, that if you don't tell patients about all the material risks, especially ones that may be important for them, you may actually be taking invalid consent. And if you were told you needed surgery and then potentially had an unnecessary stoma, I don't see that it's unreasonable for people to be annoyed about that and potentially take legal action. So who is suitable? When I was doing this talk, I thought that really it's like Cinderella's slipper. You just have to find the best fit. There's a myriad of techniques, a myriad of patient-related factors. Each one of these techniques has complexities in it. There's lots of legal and ethical consideration, and really it's more of a focus on telling one precise example, one precise treatment option, to focusing on balancing risks and joint decision making between patient and surgeon. So to summarise again, for locally advanced treatment for organ preservation, watch and wait is one option. Its local regrowth rates are between 15 to 33%. They're most common in the first 2 years. Patients need frequent follow-ups and tests to look for regrowth. There is a very high rate of successful surgical salvage, ranging from between 83 to 95%. And disease-free and overall survival appears to be similar between these patients who undergo watch and wait and regrow compared to patients undergoing an index surgical operation. Local excision, again, it's technically possible. The main concern is what happens next. What pathology mandates completion surgery? it may burn the bridges for surgical salvage, and there can be a very significant morbidity. When you get a regrowth in a local excision scar, it can be very, very difficult to manage. And certainly for me, I used to think this was a fantastic idea, but now it's not such a good idea as it intuitively seems. And I think that while it is an option and can work well when you look at the data, patient selection, patient consent, and understanding your own results is going to be key to making this technique work. Contact therapy, I think, is an exciting technique. It certainly makes radiobiological sense. It's widely available in England now, and there's fantastic doctors. I know all these doctors doing it. They're fantastic doctors, and they provide a great service. There is still no hard and fast data on contact therapy, but the other advantage of the centres offering contact is all the patient's data is stored on a specific database for contact therapy. For early rectal cancer, it's clear now that no single technique is better than another, certainly for stage 1 disease. Discussion with patients and understanding of institutional capabilities is key, and you need to audit your own results. So to summarise who is suitable, anyone is really suitable for organ preservation. There's going to be some patients that are perhaps more suitable, elderly, comorbid, morbidly obese, stomophobic, but also the surgeons need to determine if a patient actually needs a permanent stoma. Can this patient be selected for a local anal anastomosis? And if you can't do it, refer it to someone that can. So organ preservation is extremely complex and ever-changing. Surveillance needs to be very specialised, and I feel should be done by experienced and interested people. Ideally, the majority of follow-up should be done in local centres, but should be linked in with regional, national and expert centres. Surgeons should be open about their abilities and refer to specialists in low rectal cancer surgery to avoid unnecessary APRs, and ideally all patients should be tracked in a database. But then, of course, this needs resourced and it needs time to put the patient details in, and so that's something that in the future definitely needs to be addressed. This is a model we've proposed before, that this is going to be a hub and spoke model of rectal cancer delivery. Ideally, the majority of treatment, scopes, scans, etc. can be done in local centres, but it should be linked into a regional or national high volume expert centre, and I firmly believe that this is going to be the way that rectal cancer management is going to be in the next 10 years. In terms of making decisions about organ preservation, this is my own little idea, concept of it. There's a triangular decision algorithm. You've got the certainty of residual disease that you balance with a patient's wishes and fully informed consent, and then balance that against the patient's comorbidity. And then you make a decision that's in the patient's best interest. And I think that if one slide says it all, this is what rectal cancer management is going to look like in 10 years. You've got the patient in the centre, and you've got all these experts focusing in on the patient, giving advice, but ultimately the patient makes a decision and is managed in accordance with that decision. So once again, thanks for allowing me to give this talk. As you can see, it's a fascinating area with lots of really exciting opportunities, but also lots of unanswered questions. So if anyone would like to find out anything more about it or like to contact me about it, please feel free to get in touch via the ICENI group.
What a fantastic lecture that was. And we'll be discussing that in more detail later on in the programme. But for now, let's look at one of our complex MDT cases that was discussed earlier in the day. Hello and welcome to the ICENI Centre's Rectal Cancer Multidisciplinary Team meeting. My name is Greg Wynn. I'm one of the consultant colorectal surgeons here in Colchester in the UK, and I'm delighted to be able to invite here today an expert panel from around the country to discuss these difficult cases. Before we start, I'd like to get them to introduce themselves to you.
My name is Tan ARULAMPALAM. I'm a colorectal surgeon at Colchester Hospital.
Hello, I'm Ian Daniels. I'm a consultant colorectal surgeon at the Royal Devon and Exeter Hospital.
Jim Khan, consultant colorectal surgeon, Queen Alexandra Hospital, Portsmouth.
James Kinross, consultant colorectal surgeon and senior lecturer at Imperial College in London.
Anna Wordley, clinical nurse specialist in colorectal care at Colchester.
Alex Stewart, clinical oncologist in Guildford with a particular interest in brachytherapy.
My name is HUGO Ford. I'm a medical oncologist from Addenbrookes Hospital in Cambridge. My name is NAJIB HABOUBI. I'm Professor of GI Pathology in Manchester, UK.
This is a 69-year-old gentleman with a BMI of 33. He is fit and active and has hypertension as past medical history. He's presented with a change in bowel habit and anemia, and on examination he has a tumour that isn't palpable on digital examination, but seen just about on rigid sigmoidoscopy. The colonoscopy confirms a biopsy-proven adenocarcinoma of the mid-rectum, but is otherwise normal. That's what the tumour looks like. Darren, we're going to ask for some staging scans, please.
Thanks, Greg. You can see there's quite a long circumferential tumour, the distal extent of which is 6 centimetres, nearly 7 centimetres from the anal verge. The tumour itself is around 7 centimetres in length. Occasionally you can see the rolled edges, but most of the time this is circumferential, and consequently it's very difficult to assess where its leading edge is, because there are multiple areas of breach of the muscularis propria. For example, here there's no normal signal returned all the way round, and we could see that any of these may be small projections and tongues of tumour, or indeed small vessel EMVI, but there's no lymphadenopathy, and because he has a good distance to his mesorectal fascia, his CRM is clear throughout. He's also got non-enlarged but worrying right obturator node. You can just see it here. It's heterogeneous. It's around 6 millimetres in diameter, which is considered at the upper limit of normal for the internal iliac chain, but it certainly has worrying features there, and heterogeneity. So these nodes are not enlarged within the mesorectum, but again return some abnormal signal. So overall we're going to call this a T3C, but with a clear CRM, small volume non-anatomical EMVI, and N2 but with an involved obturator node. The CT doesn't show any distant disease.
Panel, what do you think?
So in the good, bad and ugly of rectal cancers, this is neither good nor bad nor ugly, but this would fit in the middle as a bad. Mm-hmm. Traditionally he may well have gone straight to surgery, but with the recognition that we're seeing of the impact of EMVI, then maybe we should be considering a neoadjuvant strategy for this patient and putting that to him, having gone through all the understanding of that he would like to go for a curative, potentially curative option.
Okay. Go on, Jim.
Yeah, so some of the limitations here are obviously we are seeing a node which is 6 millimeter outside. If that node was not in the equation, it is a resectable mid-rectal cancer. Straight to surgery would be the right thing to do. But obviously extra mesorectal disease, which question would be how sensitive CT scan is or MRI is in picking those nodes. In our MDT, we probably would recommend a PET CT, but again with the same limitation of what the accuracy of that PET would be. Having said that, a PET positive node in the extra mesorectal compartment will push you probably more towards considering neoadjuvant treatment upfront and then proceeding with surgery. We had some interest in lateral node dissections for rectal cancers, and looking back at our experience for the last 10 years, I can tell you that more than half the time we are incorrect in terms of assessing the positivity of those nodes. Even before, in the first half of the study, we only did them after neoadjuvant chemoradiation, so you never know whether this is the effect of that treatment that they are now sterilized or they were negative from day one. But in the last few years, we have gone straight to surgery for these kind of patients when the primary tumor does not need downstaging, and we have found that even those kind of suspicious nodes on MRI, half the time were negative after lateral node dissection surgically.
Okay. So suspicious node outside the field of surgery. This chap has had a PET CT, Darren.
The PET CT shows that the node is doesn't have an increased tracer uptake. So this is the next MR. I haven't got the image of that.
So it's negative apart from the primary tumour?
Apart from the primary tumour, no distant disease, and the obturator node does not show any uptake.
Okay. Are you still worried about this obturator node or not? James?
I am. So there are several options here. I'm sure Alex will tell us. So I don't want to speak on behalf of the oncologist, but we've started in our unit to do intraoperative radiotherapy as well for these suspect nodes. It gives you just another treatment option. We do that in the context of a trial and under ethical approval. But for the reasons that Jim has described, actually sometimes that just gives you another optional, another interventional option.
But if I understood right, there's vascular. You reported vascular invasion on that, extramural vascular invasion, and I would consider that more of a risk factor for this patient than I would consider the issue of a node. Accepting that my primary take on here is the neoadjuvant strategy for this patient.
So Gina's work lends support to that approach of a neoadjuvant strategy. And if you're going to do that, I would say this is an opportunity to prehabilitate a 69-year-old man who's got a BMI of 33, who you're going to try and cure. And, you know, if you take James's principles of keeping the patient safe on the table, good quality of life and best oncology, we've got to start thinking about those things up front as well. So if you're going to do a neoadjuvant strategy, we need to think in parallel about prehabilitation.
Okay, fair enough. Can I ask the oncologist what sort of neoadjuvant strategy would be most appropriate for this?
Well, so saying the feature that would concern me most about this case would be the suspicion of extramural vascular invasion, because you know, that is undoubtedly a bad prognostic sign, and I think we would tend, in these cases, to give upfront chemotherapy. But this isn't quite as clear a case as some others you might see, and certainly you know, it's not large volume EMVI such as some of the worst cases are. But we would certainly have a discussion in this case, other things being equal, about giving them chemotherapy up front, followed probably by long course chemoradiotherapy.
Can you describe your threshold from an MRI that would push you into a neoadjuvant chemotherapy rather than go straight to neoadjuvant chemoradiotherapy?
The main risk factor for us is the vascular invasion, presence of vascular invasion. You know, otherwise we've got a discussion about resectability and circumferential resection margin and so on, but none of those drive us towards chemotherapy up front. It's the vascular invasion that is the higher risk of systemic disease, and that's really the main justification for giving chemotherapy first.
Alex, neoadjuvant chemotherapy?
So for this patient with the obturator, I think once we got the PET CT, I'd take it back to the MDT and say to my radiologist, you know, how suspicious were you, given that the PET's negative, but it is only 6 millimetres, and perhaps using diffusion weighted as well. If they still came back to say that they
Should we ask Darren?
Suspicious.
Darren, how suspicious are you that this node represents metastatic disease, regional metastatic disease, outside the...
I'm quite reassured by the negative PET, even though clearly there is a false negative rate. It's around 6 millimetres. It was suspicious. I had a reasonably low a priori worry about this node, to be honest. So I think a negative PET for me, I'm now thinking this is probably okay.
So now I would say no chemoradiotherapy. And because the risk is predominantly systemic, what we do is go for the surgery first and then get the chemotherapy in quickly afterwards, because I think the patient's going to have a better bowel response if they're able to have their surgery up front with no chemoradiotherapy to start with. They've got a much higher chance of not needing a stoma even temporarily if they haven't had chemoradiotherapy. So our feeling on the EMVI is there's a lot of really interesting work coming out, but we're not using that as a sole indication for neoadjuvant chemoradiotherapy at present. So we're looking at giving the surgery and then getting the chemotherapy in quickly afterwards.
And there certainly isn't any evidence really supporting, in this sort of case, a chemotherapy surgery strategy. And the rationale for giving chemotherapy up front is that actually, if you wait till after surgery, at least 10, maybe 15% fewer people complete their chemotherapy. So if you regard chemotherapy as a critical part of the treatment, then you have a higher proportion of people who complete the course of chemotherapy.
But they get debulking too.
Well, they do, but actually, if you look at the rates of pathological CR and so on, they're not really increased. So the reasons that we would tend to do it is for the systemic risk, and also actually sometimes, not so much at the moment, but it can help you to prehabilitate your patients, plan your treatment a bit in advance.
And the Dutch studies have shown that those patients with an anastomotic leak have a poor outcome, and part of that is not getting to their chemo in that window.
So my question was going to be, do you consent your patients for that? Not getting to chemo?
So I don't. And I think increasingly we should be having that discussion. Because people, if we're talking about real shared decision making, that's a real concern. And it's not just if they have a defunctioning stoma, then it's the window to reverse that, and you've got another operation with complications to get them in. So I think it's a really important surgical strategy, which I don't think we should take lightly.
We don't consent. Sorry, we consent people to complications. What we don't do is consent them to the impact of the particular complication.
Yeah, that's very good.
We tell them about this may happen with your surgery, but we don't discuss with them necessarily, and we should, what the implications of an event today may be in 3, 6, 9 months' time. And that comes down again to the shared decision-making and the whole process of taking some of our inherent bias out and offering the patient the options to weigh up.
But it's, as a patient who this is happening to them for the first time, to weigh up that information is incredibly difficult when you've just been told you've got cancer. So I think it's a really difficult issue.
These are difficult conversations, and you can't do that within 10 minutes of allocated time. So you have to probably see the patient 2 or 3 times at different intervals with their family members, and then you can reach a kind of a joint decision-making or share the responsibility for that decision-making. I just wanted to back Alex on this point that I think in our MDT as well, if you see somebody like this who we think is at higher risk of systemic disease because of the EMVI, they need to have chemotherapy up front, and we would go with systemic chemotherapy treatment up before surgery again. We are not gone down to total neoadjuvant treatment up front, where you give all the chemotherapy before surgery, but we will try to give them at least meaningful 3 months of chemotherapy up front. But on the other hand, the radiation usage, again, the CRM was clear, and we will try our best to avoid radiotherapy in this setting if we can. We contributed to Bacchus trial, and I was going to ask Dr. Ford whether you have heard any preliminary results of the Bacchus trial that was set primarily to check this question of whether you give systemic chemo or give chemo red up front, or is there any difference in giving it up front? I haven't read any results published on that.
I'm not. And the other trial is the RAPIDO trial, which is looking at chemo rad versus just chemo rad, which is a sort of more standard treatment approach. But again, I haven't heard any results from that yet for efficacy. Have you, Alex? No?
Not yet. No.
Okay, we're going to move things on. So we know that this obturator node is negative, and the gentleman was sent off for neoadjuvant chemotherapy, 4 cycles of Capox. He developed DVT around his PICC line and was restaged.
So there's been a good partial response to treatment so far. You can see here on the sagittal views there's already a little fibrosis, particularly around the deep wall. The lumen's full of fluid, and interestingly, given that no radiotherapy was given upstream from this, there's a colitis with some submucosal edema and some perienteric inflammation. That complicates the assessment because there's also edema proximal to and distal to the tumour, and also involving the treated segment. The EMVI is now fibrotic and looks completely resolved. For example, this little nodular vein here is a densely fibrotic signal, and while there are some strands and spiculations extending into the mesorectum, there's no discontinuous tumour, and there's no convincing extramural tumour nodule. Nevertheless, there is some residual tumour in here, some intermediate signal intensity, particularly towards the distal end of the tumour, so we can't call this a complete response. Fibrosis predominates over tumour signal, so we would call this a TRG3 by MR criteria, a sort of moderate response to treatment. Now, the little obturator node has reduced in volume. It remains slightly heterogeneous, but that's at the limit of MR resolution. There's probably a little bit of low signal centrally within there, but that looks like it's got a bit smaller. Now, whether that means it was previously reactive or whether it was previously involved, I don't really know. The fact it's got smaller perhaps may suggest that it sort of mirrors the response within the primary tumour, which is a little worrying, really. But at this stage, we're saying it's TRG3. CRM remains clear, and this would be N0 EMVI negative at this stage.
Thank you. So, proceed to surgery, get a regrowth in the obturator node, or chemoradiotherapy?
I think it probably, as James said before, you have a few options on your plate and you have to play to the strengths in the unit or where you're practicing. So the option essentially in this situation would be to go for LAR plus lateral node dissection if you're trained enough and experienced to do that. It will be to give radiotherapy for that node. I will be worried about that node. The fact that it's got smaller with treatment in comparison with the primary tumor is a little bit more suggestive that the nodes may be involved. The tumor is mid-rectum, which is at the right level, and he had EMVI, so if there is a lateral spread, this is the site where this will spread to lateral node dissection. So in my setup, we would be offering him lateral node dissection at this stage along with LAR, but you have the choice of giving him chemoradiation and boost to the lateral pelvic node or intraoperative RT, as James mentioned.
Okay. Anyone else have any very strong opinions about what happens next?
So I'd be offering him, well, I would say we would be offering him chemoradiotherapy as part of this ongoing strategy. Given that he's had response already, but this, by my definition before, is a bad tumour, then I'd want to get maximum local control as well as reduce his risk of systemic, and then surgery at a later date.
I think we would do the same.
Certainly our MDT, that would have been part of the original treatment plan. I think if we weren't going straight for surgery, we would have been gone for chemoradiotherapy at this stage.
Okay, this MDT approved, and he's got some 8-week post chemoradiotherapy scans, Darren, for us to look at.
Okay, so you can see that the tumour has continued to reduce in craniocaudal length and radial thickness, but there's some slightly concerning new intermediate signal intensity anteriorly. Now, there's quite a lot of motion on here, but there's the impression that perhaps there is some residual active tumour anteriorly breaching through the muscularis propria and in towards the to the peritoneal reflection. The EMVI remains fully fibrotic, but the little right-sided obturator node has also crept up again in size at this stage, again measuring around 6 millimetres in diameter. So what we have is a, rather than continued response, it looks like it's gone the other way, and the tumour is starting to predominate over fibrosis, perhaps with some breach through the muscularis propria anteriorly, potentially sufficient to involve the peritoneal reflection. EMVI remains negative, but the pelvic sidewall node is now becoming more worrying again.
Okay. Comments on that?
Well, it's quite unusual. I mean, if you if you look at the trials with that sort of treatment strategy, the number of patients who actually progress is only about 1%. So it would be unusual to see progression after that treatment strategy. But obviously, it is a cause for concern because it suggests if it is progressing, that's unfavourable biology.
In our data set, we found that figure to be relatively higher, around 10% progressing on radiation, especially with mucinous tumours. And you look at the subset of the tumours which we can identify now, in retrospect, they have a higher risk of progression on chemoradiation, 10% or less.
My other question is what sort of value do you put on the MRI TRG score in your decision making? So I know that there's a lot of work that Gina's doing on the trigger trial to try and answer these questions. But does that, he was a TRG3 on reflection. That sort of puts him right slap bang in the middle. Would that have changed your?
But this is exactly the group of patients in whom trigger is aimed at, because this is the group of patients. This is what we're trying to ascertain is which patients benefit from a neoadjuvant strategy, as opposed to the mass that, and traditionally, there were patients with too good a prognosis being treated with neoadjuvant expecting too much response. And this comes back to what I said before. This is that bad group of cancers in the middle that we're not entirely sure, or we're not sure what to do with. Now, I'm with you in our series in Exeter. Those that progress on treatment seem to do appallingly in terms of their ongoing management, both in terms of local and distant disease. That biologically their disease seems to be resistant to treatment. And then it's not the norm by any means. But then I would have been concerned about operating on him, now knowing his biology, and potentially leaving disease there and local occurrence. I think, unfortunately, we are, irrespective of all the tools that we have, we're fighting something here which is biologically not favourable. Had he had a complete response, he's biologically very favourable. But there are always people that are unfavourable as there are people that are favourable.
But if we go back to his post-chemotherapy scans, we thought that it was TRG3 without any CRM involvement, and we got pushed into giving him radiotherapy because of the lateral side wall node, which we are not sure whether it's involved or not. It was PET negative. So is there a subgroup of patients who actually give you a window of opportunity of operating earlier, and whether his systemic disease was responding well to chemotherapy that he had, but his local control was going to escape? And that's what we saw in the follow-up scan 10 weeks later after finishing his long course.
I think there is a case, as you say, to intervene at that point, but you possibly have to use another strategy with it. So intraoperative radiotherapy.
We are not very good at picking up which are those patients which fall into that group, but there is a significant proportion of these patients where after long course chemoradiation you miss that window of local controls.
Would a PET have helped? Sorry, Alex.
Sorry, I was just going to say I might not have waited quite so long for the post-treatment scans. So we'll do 8-week post-treatment scans when we're using just neoadjuvant chemoradiotherapy. But if we've used chemotherapy first, shown some response, and then we're using the chemoradiotherapy, I'd usually scan at 5 weeks and be looking for the surgery at 7 weeks. And there was some data coming out from Brazil that the patients that are progressing seem to take off around the 7-week mark.
But there's also data that demonstrates that operating at 14 weeks compared to 7 weeks gives you increased complete response rates.
When you're only using chemoradiotherapy, not in the situation where you've already given them 3 months of chemotherapy and got your downstaging from that.
But the surgical morbidity is also less at 14 weeks as it is at 7 weeks.
Some studies show that, some don't.
But the truth is that a tumour with bad biology is a tumour with bad biology right from the start. And we don't know, actually.
Did he have a 4-week scan or no? We don't know that.
Whether there's anything to be gained by accelerating the surgery on these patients.
No, he was booked for a 6-week scan and he was just 2 weeks late because of build-up incapacity.
So we are spending all our time looking at structural imaging, and James, I want to ask you about the biology, because I think this is something we perhaps don't talk about?
So this is, it's the big elephant in the room, and it's always, I'm slightly anxious to talk about it because it's sort of heresy, really, and I know Gina always gets herself into trouble because she sort of says, well, when is a lymph node, and is really lymph node metastasis the route that we should really be worrying about, and is that lymph node actually not just a tumour deposit? And the bottom line is we don't really understand what the fundamental biology is actually in these patients. I'm talking about at a molecular level, right? So when you look at distant metastatic sites like in the liver, probably in over 65%, the clones don't represent what's in the lymph nodes actually. And so tumour evolution fundamentally changes. So I don't think we have robust biomarkers to help guide therapy, as evidenced by our recent discussion.
So if we're going to get a paradigm shift in thinking, we're going to our MDTs week in, week out, year in, year out, and we look at these and we come back and we just say, oh, we couldn't have picked that one up. What can we do? You know, is biobanking a good thing to do? Do you want us?
So I think that's a big question, and there's two answers to it. Just, you need a pragmatic answer, like what can we do now in our MDTs to help us, and then what do we want to do in the future? Of course, in the future we need to biobank, and we need to be thinking about prospectively studying the biology of these cancers, and I know there's lots of groups around the world trying to do that. But I think there also needs to be a slight change in our strategic thinking. As surgeons, we think very practically. We think about histology, we think about imaging, we think about operating. We don't think about how upfront tumour biology is going to influence our operative decision-making in the way that oncologists do. Like, oncologists want to know about mutation status. They want to know about mutation burden, and it governs their strategy. It doesn't in surgery. And I think that's probably what needs to happen.
Even in the mismatch repair group? Even in the mismatch repair group in which that chemotherapy may or may not work?
No, what I'm saying is, though, is that comes into the oncological strategy.
Yeah.
An oncologist looks at the molecular biology and then will base their strategy on that.
Okay.
Surgery, we don't. We look at imaging, and if we're lucky, we get some histology, and then it's an afterthought.
So if we're really going to go down and change the paradigm, I think particularly as surgeons who think in structural imaging and then what's in, the person in front of us, we need to think very differently about the biology of the person that we're operating on.
Yeah.
But we're seeing that. Sorry, we're seeing that already. So from the patients that were put into the 100,000 genome project, unfortunately, it's 3 years now it's taken for us to get the analyses of those patients' tumours and their DNA, etc. And for people who have been treated 3 years ago, we've got considerable variation in the expression, both within between tumours and within individual tumours. So some people seem to have very homogeneous tumours, and some people have very heterogeneous tumours in terms of what is being expressed in them. And at the we've gone through the discussion of now we're getting all these results. What do we do with them? Because it's taken 3 years to get that biology back.
But that was, the 100,000 Genomes project was a national biobanking project. It wasn't designed to answer surgical questions. I know that the Birmingham group have the ESCORT study, I think, perhaps slightly controversially named, to try and work out how we can use precision-guided molecular data to change operative decision-making. But I don't know of anything that's going to give you the answer that you need in the time frame that we have to make surgical decisions.
So this tumour heterogeneity is quite interesting, and we've taken one step towards trying to get to the molecular way of assessing our patients. And perhaps, Darren, I don't know whether you have any views on our work using TexRad to look at the texture of our MRI imaging as one of the adjuncts to trying to give a decent prognosis and try and stratify these patients slightly better.
Yeah, I think there's two very similar but slightly disparate questions there. One is about diagnosis and one's prognosis, and interestingly, in terms of trying to establish which of the MR biomarkers, if you like, for lack of a better term, give us any idea as to which tumours are more or less likely to respond to treatment, that's incredibly interesting, and certainly we've seen some results there ourselves. But I think that the future of this will be multi-parametric imaging. It will be bringing together DWI, PET MR fusion, dynamic contrast, all the other individual potential biomarkers to try and not only prognosticate, but also, in this case, for example, given that everything pointed towards things not adding up, the fact that he appeared to progress through treatment, you'd have to start thinking, well, maybe we should be bringing DWI to the table rather than just purely depending upon structural features. But of course, the majority of the structural, it's the research that's shown structural changes is where we're basing our decisions at the moment, because that's got the biggest evidence base. And in fact, there's there's reticence to rely upon things like DWI because we don't really understand it, and we don't have large studies with more than a few dozen patients involved. So things like texture definitely show promise, but I think we have to have the structural side of it down and a solid evidence base before we can start bringing in the other elements of the multiparametric imaging.
So this is a very fascinating subject, and maybe the subject of a future lecture. But the patient is sitting in clinic, and he's been waiting a long time. He wants to know what's going to happen next. So can we have some management decisions, please?
We have to ascertain what his symptoms currently are at the moment as well. He has been through considerable amount of treatment. He's no doubt become quite deconditioned unless we put a strategy in place to maintain his fitness, etc. And to ascertain just what his bowel function is like, but his entire health and his pelvic function as well. And where he's at with all this, because he's been through quite a lot of treatment now over the course of quite a number of months.
Okay, his symptoms are slightly better than they were at presentation, but no better than that.
So for me, this is a question of how we react to the, so regardless of what we think about the discussion we just had about being proactive and knowing more about the tumour up front, this is about how we react to what we're seeing in front of us. So what we're seeing in front of us is a man who we suspect strongly from the radiology, we can't be sure, we suspect from the radiology has disease with a bad outcome and a high risk of systemic relapse, right? But he also has a very high risk of morbidity from his primary tumour if uncontrolled. So I think the question for me is, what is the conversation that we have with him at this stage about the pros and cons of having his operation versus, I think probably unproven, but versus going on to some sort of different systemic therapy strategy. Is it worth him having surgery? Is the morbidity of him having surgery worth the local control benefit, given that he's got such a high risk of systemic relapse?
He says that he's fit and well, he's in his late 60s, got no comorbidities, there's no metastatic disease. Please, can you just get this thing out now? That's what he's saying.
So if we're going to get this out now, what is the operative strategy? Is there a place for, it's not just a standard TME, whether you think about a beyond TME type approach. And that's a different kettle of fish in terms of a peripheral hospital MDT than attempting to do a very different type of surgery which needs a different skill set and support. So what do you think about that?
No, absolutely agree. I think if I understood the MRIs correctly, he's got kind of disease going on the peritoneal reflection anteriorly. He's got a risk of a closed margin at that level. So he would need surgery beyond the normal TME paradigm. And that if that is the way we're going to go forwards, then that's best done by people who are doing it on a more regular basis, and the team who are used to deal with these situations, assess and interpret those scans and perform surgery, whatever modality they use to choose, open or robotic or laparoscopic. But it will be complex surgery. And I think that you can make a case for such kind of interventions to be done in centers where they don't do that once a year. They are more frequently exposed to this and have a strategy to deal with the potential complications. Because at the end of the day, the discussions with him is going to be around what are the risks of a positive margin in this situation, what would be a plan B if it is an R1 resection, and what morbidity and complications he can expect from surgical intervention. If those figures are very high and he's a switched-on 60-year-old chap, he may decide to consider second-line treatment, as Dr. Ford mentioned, to consider that as an option, to buy some time and assess the biology of the disease to see whether this is going to be a futile exercise to go down the route of anterior exenteration or beyond TME surgery in this setting.
Yeah, so I agree that this is a both a difficult management but also a difficult surgical decision. Also in terms of whether you think about putting him back together, give him a loop ileostomy, he's still got potential disease. He's got, the presence of his ileostomy never getting closed. He's got potential. I consider him high risk for both local failure as well as potentially distant metastases, given his original presentation. So if we're into a more radical surgical approach, I think given that you want to also try and minimise his morbidity, because you are almost certainly perhaps going to be looking at further adjuvant chemotherapy, then I'd want to operate on him and offer him an operation that gets him out of this situation, but doesn't necessarily increase his risks of complications. So I'd shy away from offering him an anastomosis.
I fully agree with that. I think end colostomy would be the most appropriate thing, not knowing that we got local control, not adding the extra complications to stop him from getting on to the next step of his treatment. Absolutely right thing to do.
Would adding an endoscopic view be helpful at this point? Given that his symptoms are a little bit better.
Do you want to have a look inside?
Why not? Have we got a picture?
No endoscopic assessment. And he proceeded directly to a low anterior resection with loop ileostomy. Right. In fact, he made an uncomplicated recovery. So a standard TME, really. And we're taking a chance on that obturator node. So Najib, can we just have before we go any further, because we had a lot of discussion on this case, can we just see what the pathology showed us?
Well, actually, when the pathologist opened it, there was a slight area of fibrosis or scarring within the lumen. So there's some sort of mucosal scarring. However, that is on macroscopic analysis. Histologically, there was no tumor. It was a complete response. 24 lymph nodes were recovered. None of them contained any lymph nodes. And I think we have to separate between complete response within the tumor versus the lymph nodes, because there are about 8 to 9% of cases, according to the Cleveland Clinic, of complete pathological response in the bowel, while actually the lymph nodes are still involved. So I think here this is a complete success story regarding the completeness of excision, and also there's no evidence of venous invasion, lymphatic invasion, or perineural invasion, and it is R0 all the way through.
So you say complete success, but that was the way.
Well, the pathologist was very happy.
Yeah, the pathologist very happy.
Yes.
But from a consent and a Montgomery point of view, this patient hasn't had an endoscopic assessment, and we certainly have knowledge of litigation where the patient has had a complete pathological response and says, well, why do you do the operation? So I think...
So in this case, the two areas that you were worried about were extraluminal. So if you'd done an endoscopic assessment, you wouldn't have seen those two areas. And it did not appear to be a complete pathologic response on the imaging. I think if you had a case where it's a complete pathologic response on the imaging and you didn't take it forward and offer the patient a watch and wait approach, that's a different situation in this case. And I think in this case, proceeding to surgery was definitely the right thing to do.
Which, if this case were to set the line, we should be scoping every patient who has neoadjuvant chemoradiotherapy before surgery. And this is where we're on the science of small numbers here. We've given the accepted treatment pathways and accepted modalities that we've got. We're never going to be 100% correct. We are, after all, explain to patient risks and benefits.
So I think there is an argument that you should reassess everyone endoscopically, right? But I don't think in this case it would have. If you'd had a normal endoscopic assessment, I would still have recommended the patient to go ahead with surgery. So as a non-surgeon, but I think
you are in good company actually. The surgeons who argued that if there is a response, and probably there is still a risk of having tumor is already there, don't leave it inside.
Yeah. So I think the point is, this was, as you say, extraluminal, but I think it's an important, again, Fraser Smith is very clear, and the work from Andrew Renahan is very clear that we have to be mindful of it. So perhaps not appropriate in this case, but in those cases where there is a chance of a complete response, we have to make sure that we've gone through the right steps and had that discussion.
I think it's a good habit to have to explain when you have the pre-consent meeting with the patient to explain all this, because we had an incident like this, a very similar story. Patient has gone through surgery, then one of my registrars writes to the patient to say, just to let you know, Mr. So-and-so, you'll be delighted to know that the bowel has been removed and assessed and there's no evidence of cancer in the remaining bowel. And the patient, instead of being happy, was very upset that you have given me an anterior resection and you're saying that there was no cancer in it. And we have to have a couple of more meetings to counsel him and explain him properly. And all of that extra work could be avoided, as you say, if you set the expectations right from the beginning and say, after all this adjuvant treatment, the possibilities are this, this, and this. You may end up having an R1 resection. You may have complete response. We don't have the tools at this point to give you the answer, but unless we remove the bowel, we won't be able to answer that question. So setting the expectations right prevents a lot of problems afterwards.
So it's a lot to consider here. I just want to wrap this up because we are running out of time. Anna, can I just ask you, do patients think this is a great success, or are they...
It will depend very much on the patient, and as Jim said, the pre-operative counselling and preparation for. I mean, it's not unlike rectal polyp cancers that might have some poor features that suggest they need something more, but we then have nothing within the specimen at all. And I would say the majority of them are very thankful because they've been counselled appropriately. They know there is no other way of knowing unless we do this. I think those patients who are making a very good post-operative recovery with their quality of life returning to near normal pretty quickly accept it more than those who are struggling with that.
Absolutely. So those that get complications may not feel
absolutely.
Quite
So what we've effectively said is it's the communication with the patient all the way through,
absolutely,
which has been key to this case. He's taken on a high-risk surgical strategy, you could argue, and a high-risk oncological strategy, and got a very good result at the end of it. But that doesn't mean to say the next person in the room will. And I think that's where it comes down to individual choice and individual discussion. It's the individualisation of treatment.
Yeah.
Jim, are you still worried about that node? Because it's still in the patient.
Well, with this kind of response on pathology, I think we just need to keep an eye on that.
Okay, we're going to move on. So the key learning points for that case was an assessment of response to neoadjuvant chemoradiotherapy on imaging alone can be really difficult sometimes. And as Hugo said, when something seems unusual, it requires careful consideration of other possibilities. This case didn't really fit the usual pattern, and we need to stop and think and perhaps do something different.
But you have not totally cured him. There's still potential of distant metastasis, though.
So he's 2 years down the line from surgery now, and he has no evidence of recurrence.
No, recent CT scans completely normal. CEA is 1.
So welcome back. We're up in the ICENI Centre lab, and I've got my colleague Professor Tan ARULAMPALAM with me to discuss things in more detail. Tan, we've just seen a fantastic lecture from Fraser Smith, always a great speaker. He's given a very comprehensive lecture on organ preservation, complete responses and all the rest of it. I think he's gone through it in from the local excision of small rectal polyps, early stage rectal polyps, all the way through to the more serendipitous finding of stumbling across a complete response and knowing what to do in that situation as well. Well, what did you think?
I thought it was fantastic. It really was comprehensive, as you said. It covered the whole range of scenarios. I think what's interesting is that this is probably in the whole population of patients with rectal cancer. It's a relatively small group, but we have to be aware of them, and I think far too often we can have pressure to treat people because they're on certain pathways and timelines. So I thought he highlighted the different ways in which we can end up with a complete response. What was your sort of takeaway from that talk?
I think that if someone's had a very good response after neoadjuvant chemoradiotherapy, or short course radiotherapy for that matter, or even neoadjuvant chemotherapy in some situations, that's the time to stop and assess and communicate with the patient. So if you've had a very good response to neoadjuvant therapy, you're already in a better prognostic group. Yeah. And I don't think there's any, as you quite rightly say, there's no reason why you should be rushing into surgery at that stage. That's the time to sit down with the patient and say, look, we're in a good place, we can reassess. I think the MDT case that we saw following the lecture highlighted that I think you should really use all the modalities at your disposal, including MRI, of course, clinical examination and endoscopy particularly, because you might get a surprise, you know, and you've got to correlate those modalities together to come to a conclusion that you can then present to the patient. I think, as Fraser says quite rightly, I don't think you should be in a situation where you get a pathological complete response in a specimen and be sitting down with the patient and saying, well, this was a complete surprise. I think you should have been either suspecting it and then talking to the patient and their family and saying, well, where do you want to go from here? And if they want to pursue organ preservation pathways, then that should be taken into consideration.
I think you're absolutely right. I can remember I was with Bill Heald. We were travelling to visit Angelita Habragama in Sao Paulo. And he just said, you just don't need to rush with these patients. And I think that was back in 2007 or so. And you know, the world was a different place then, as you know. And I think you were there, weren't you, in 2007? And he said, you know, you need to bring in the four corners of the MDT. So we need the specialist in, you know, attention of the radiologists, the oncologists, as well as the surgeons and the pathologists. We definitely need to use every modality and triangulate to get all the information. You know, we've gone beyond the age of the master builder who knew everything. You know, now there's so much information out there about each patient. We need to be able to share it. And you know, it raises a question in my mind. You know, when we're following up these patients, you know, one, you've got to be alert that this is a possibility. But then you've got to think about who's going to do the assessments, don't you? What's your view on that?
Well, I think we've seen a few speakers now talking about rectal cancer management in a sort of hub and spoke way. And there have been calls for centralisation of rectal cancer services, certainly some of the more specialist areas in rectal cancer services. I think for those people who are not happy to manage a near complete response or a suspected complete response, then I think they should really be looking to someone else who maybe is happy to manage that in a more specialist centre.
But I think even within an MDT, there's no harm. I really don't think there's any harm, as you very well know, in just saying to a colleague, listen, what do you think? I think it is very helpful because you can sometimes get quite tunnel visioned.
But it does depend on who you ask as to what the answer is going to be.
Absolutely, absolutely. And I think it goes back to being open-minded. But you made a very important point about Montgomery and consent, because I can remember during my training we may have have had a complete response, and it was cracking open the champagne and celebrating that. But actually, in this day and age, you and I would not want to have gone into that scenario, because actually that patient has had a major operation with significant morbidity associated with it. So there are issues there, aren't there?
There are. And of course, patients sometimes would want radical surgery. They want the certainty of radical surgery, but that's not the point. The point is that the care has to be tailored to that patient, and patients who come into my clinic have a whole wide range of different views on this subject, and some of them will want to avoid surgery at all costs, and some will want the certainty of surgery. So it's about communication and tailoring care.
I think absolutely, and I think we never want a patient to be in the situation where they say to you, if I knew then what I knew now, I would have thought differently. So I think consent and those processes must be done with an advocate for the patient, definitely, and I think we need to explore all the options and lay them all on the table. And then it's proper shared decision making.
Do you think we've got enough evidence now to be offering a watch and wait pathway outside of a clinical trial to patients who really want it?
So I'm going to answer that in two halves. I think there's 100% evidence that we should have a discussion about the possibility of a complete response with a patient. So, Andrew Renahan's paper, which was the propensity score matching, really showed that, watch and wait is something that applied to the correct patients is a positive thing. So that's good. It must be discussed if there's a possibility of a complete response. I think managing it as a sort of individual surgeon, individual hospital, we may face criticism, and I think a registry is the best way of doing things, and of course there are registries now that we can use, and I think it's about surgeons talking to each other so that if we do see adverse events, they can be flagged up quickly, and that's why I think we need the totality of the data rather than surgeons perhaps doing their own thing.
I think the emerging data that perhaps salvage surgery for regrowths is quite successful in curing disease may swing it for some people. That might be the icing on the cake to say, yep, there is definitely mileage in this, and we should be thinking more and more about potentially getting to that point rather than aiming for surgery per se.
So again, that's the Brazilian data, and I think Fraser Smith was part of that group that looked at that salvage, and the results are good, but it depends on your surveillance program. And again, this comes back to who does the surveillance, which modalities are used, and of course some patients, as you mentioned, some patients can't live with the anxiety of that series of scans and flexible sigmoidoscopies, but you have to weigh that up against the huge morbidity, the huge cost of the radical surgery, and I think that's one has to have an honest conversation, and that takes time, and it may be 2 or 3 conversations to make sure that everyone has understood what's going on.
Good, okay, I'm sure we could talk about this all evening, but I'm going to have to cut you short there. Well, thanks for coming to talk to us.
It's a pleasure, thank you.
Thank you. So we've seen some fascinating things discussed during this episode, and hopefully that will stimulate some discussion and new ideas back in your hospital as to how to improve the care that rectal cancer patients receive locally. Remember, if you'd like to get in touch with the ICENI Centre through any of the routes shown here, then please do so to give your feedback, and we look forward to welcoming you next time. Goodbye.